These drugs are well tolerated. They're safe. Fewer than 10% stop treatment for toxicity. The number is about 2% for Selpercatinib. Again, what's important here is that the on-target effect of RET inhibition is not really relevant biologically. When we block RET, there's not much consequence to doing that. The toxicity of these drugs is mostly related to the inadvertent or spillover blockage of other proteins. Here's a table showing the side effects of Selpercatinib. Now, if we look to the right, those that are related to treatment, we see about 30% have edema, but mostly mild, low-grade edema. We can see diarrhea, 27% with fatigue, and 38% with dry mouth. Some of these are paper toxicities, things that don't cause symptoms but are important to monitor, like AST and ALT elevation. Those are liver blood tests. We don't want that to get too high. Some are things that we can only find if we really go looking. At the bottom, you see EKG, QT prolongation, not something that patients will typically feel, but something we can monitor and watch out for. These are generally low-grade side effects, and they're not related to blocking RET. RET lies very close to some other kinases, and so when you block RET, you're very likely to block things that are closely related to RET, such as VEGF, which is responsible for some side effects, like hypertension, which is seen in about 28% with Selpercatinib. Now, when we look at Pralsetinib, there's a little difference, though. Pralsetinib has more hematologic toxicity, meaning it lowers the blood counts much more. We see neutropenia in 47% with previously treated, 43% treatment naive, so overall about 46%, but mostly low grade. We can see higher grade rates of lower neutrophils, lower white counts, lower red cell counts. These generally respond to dose reductions, and so in the early stage of starting either medicine, we have to watch with blood tests and make adjustments if we see these blood counts coming down. But the lower blood counts is something that is much more pronounced with Pralsetinib than it is with Selpercatinib. At the same time, we don't see as much edema. We don't see as much dry mouth. And so the side effects are a little different between the two. So there are some in common. All right, hypertension or high blood pressure is seen in about a quarter of patients with both drugs. So we're starting a new RET inhibitor. We want to watch blood pressure periodically because that can go up as a result of this medicine. Liver enzyme elevation, about a third of patients in both drugs. So we need to watch with blood tests after starting and periodically. Lower blood counts, a little more common with Pralsetinib. Dry mouth and edema, more common with Selpercatinib. And so when we start these medicines, important to counsel patients on what to watch for and important to follow patients closely. At the beginning, we don't want to start a medicine and say, come back in 6 months. In a few weeks, we want to do some blood tests, check blood pressure, make sure patients aren't having side effects. If we see those types of side effects, we need to lower the doses. There are some unique toxicities. Hypersensitivity reaction has been described with Selpercatinib. This is an uncommon event that usually occurs pretty quickly. It's a rash, like a diffuse rash, head to toe, fever, joint pains all over, hands, elbows, arms, hips. You can see low platelets. You can see rising liver enzymes. You can see, in severe cases, a drop in blood pressure, heart rate, kidney injury. It can be scary symptoms with this hypersensitivity reaction. Now, this generally occurs if someone has started with immunotherapy. We touched about this a little bit in some of the earlier sessions, but when we give a targeted drug after immunotherapy, it changes the side effect profile entirely. And these drugs are much more toxic after immunotherapy than if they were given first, which is why we want to use these drugs up front and why we need to test for these drugs before giving immunotherapy. If we see this, we have to stop treatment, give steroids, and then you generally start really low and titrate up as tolerated. Then you can salvage treatment, you can re-escalate, but it is a little challenging. And shown here is a picture of the rash for one of the patients. There's also the development of Chylous effusions, and these can be pleural effusions or they can be ascites, which is fluid in the abdomen. It's seen in about 7% of patients getting Selpercatinib. We don't know why this happens. It doesn't seem to be related to the cancer at all, and for some reason we do not see it with Pralsetinib. You can see it with other oral drugs as well, and most of them occur kind of late after being on treatment for a while. I think the important thing to recognize is that sometimes a doctor might think the cancer is getting worse when really it's this unusual side effect. And so if suddenly on a CT scan we see an effusion start to grow, you might say, well, it looks like the cancer is no longer responding to treatment. In those settings, it's important to verify that by draining some of that fluid. And if it looks like this, That's not necessarily related to the tumor at all. That might be an unexplained side effect of the drug. This is an important one too. There can be a false renal insufficiency. When we look at our kidney function, our renal function, we make a guess based on a blood value called the creatinine. Now, that creatinine is usually a pretty good marker of how well the kidneys are working, but there are some medicines that will make your creatinine rise, even though your kidneys are working perfectly. There are other ways to measure kidney function, like a blood test called cystatin C, that show us the true kidney function. But Selpercatinib and Pralsetinib, both of our selective RET inhibitors, fall in this category, where you take these medicines and over time you can see a rise in creatinine, but that doesn't mean the kidneys are working less well. And that's important to realize, because sometimes people will have their doses of medicines dropped when really it's not a side effect of the pill and it's not a dangerous thing at all. You see that with Selpercatinib and Pralsetinib, but you see it with a lot of the drugs we use here and a lot that Dr. Nagasaka mentioned: Crizotinib, Lorlatinib, Brigatinib, the MET inhibitors like Capmatinib and Tepotinib, and Entrectinib, as well as first-generation inhibitors like Erlotinib and Gefitinib. And so something to keep in mind when you see that rise in kidney function, it might not mean what we think.